Q1. Increased human chorionic gonadotropin, HCG, in the absence of pregnancy, may suggest which one of the following? Options. A. Carcinoma of the cervix. B. Uterine choriocarcinoma, hydatidiform mole. C. Carcinoma of the uterine corpus. D. Granulosa cell tumor of the ovary. E. Leiomyoma. Answer is B. Uterine choriocarcinoma, hydatidiform mole. Explanation. A complete mole contains no fetal tissue. 90% are 46XX, and 10% are 46XY.1. Two complete moles can be divided into two types. Androgenetic complete mole, homozygous, 80% of complete moles, and heterozygous, 20% of complete moles. The biparental complete mole is rare. With a partial mole, fetal tissue is often present. Fetal erythrocytes and vessels in the villi are a common finding. The chromosomal complement is 69, XXX or 69, XC. Gestational trophoblastic disease like hydatidiform moles, molar pregnancy, or choriocarcinoma may produce high levels of beta-HCG, due to the presence of syncytial trophoblasts, part of the villi that make up the placenta. Despite the absence of an embryo, this, as well as several other conditions, seminoma, germ cell tumors, teratoma with elements of choriocarcinoma, this is rare, and islet cell tumor, can lead to elevated HCG readings in the absence of pregnancy. Q2. A 13-year-old patient has had regular menses for 1 year, with debilitating pain beginning in the lower abdomen a few hours before menses and lasting 24 hours. Physical examination is completely normal. Optimal management at this time is: options. A. Psychiatric referral. B. Diagnostic laparoscopy. C. Trial of oral contraceptives. D. Trial of prostaglandin synthetase inhibitors. E. Reassurance with follow-up evaluation in 6 months. Answer is D. Trial of prostaglandin synthetase inhibitors. Explanation. Dysmenorrhea is defined as a severe painful cramping sensation in the lower abdomen, often accompanied by other biologic symptoms, including sweating, tachycardia, headaches, nausea, vomiting, and diarrhea. All of these occur during or just before menses. The term primary dysmenorrheal is reserved for women with no obvious pathologic condition, and this is due to the effects of endogenous prostaglandins. A. Dysmenorrhea in a 13-year-old is usually due to the effects of endogenous prostaglandins. B. Usually, no visible peritoneal pathology can be found in primary dysmenorrheal. C. Although OCPs have been used for this condition, they are not as effective as prostaglandin synthetase inhibitors. E. This pain is debilitating to the patient. Reassurance with follow-up evaluation most likely will not decrease her pain and discomfort. Q3. A 14-year-old girl is brought in by her mother for monthly cyclic pelvic pain. She has never had a menstrual period. At age 10 she began developing breasts, followed several months later by pubic hair. She is 5 feet 7 inches tall. Currently she has Tanner stage 4 breasts and Tanner stage 4 pubic hair. On perineal exam you see a suburethral bluish bulge. Rectal exam notes a midline fullness. The most likely diagnosis is: options. A. Transverse vaginal septum. B. Imperforate hymen. C. Gonadal dysgenesis. D. Complete androgen insensitivity syndrome. E. Congenital adrenal hyperplasia. Answer is B. Imperforate hymen. Explanation. This is a young woman with normal height and normal breast and sexual hair development. The lack of a menstrual period is due either to a lack of the uterus or a blockage in the outlet of the menstrual efflux. The large suburethral bluish bulge, which can be palpated rectally as a midline mass, is a vagina full of menstrual blood, hematical pus. The treatment is to incise the imperforate hymen and allow for normal menstrual flow. These young women are at higher risk for endometriosis. A transverse vaginal septum is higher in the vagina and is due to a failure of canalization of the synovaginal bulb in utero. A transverse vaginal septum is due to failure of the synovaginal bulb to canalize during embryogenesis. This would be further back in the vaginal vault. C. No secondary sexual characteristics should be present. D. Absence of androgen receptors would mean that there should not be any sexual hair. E. This will lead to ambiguous genitalia at birth and heterosexual precocious puberty. Q4. A 15-year-old patient request evaluation of masculinization and failure to begin menstruation. She was taller than her peers during childhood. Pubic hair growth began at 6 years. Excessive facial hair growth began at 10. She now shaves 3 to 4 times a week. She is 150 centimeters, 63 inches tall, and her BP is 120/80. She has prominent musculature, and her breasts are Tanner stage 2. Pelvic exam reveals an enlarged clitoris, moderate posterior labial scrotal fusion, and a cervix in the vaginal vault. There are no pelvic masses on bimanual exam. This patient's sex chromosomes are most likely. Options: A, XXB, XXY, C, XXY, D, XXXY, E, XYY. Answer is a XX. Explanation: this patient is demonstrating signs of increased androgen production, as her secondary sexual characteristics started appearing at age 6. She has, by definition, had a heterosexual precocious puberty. Since a cervix is present, the Müllerian system must have developed, meaning that the gonad is not testes, and that there is no Y component to her sex chromosomes. Her most likely sex chromosome pattern is XX. The presence of a Y chromosome would lead the gonad to develop into testes. Anti-Müllerian hormone would be produced, and no cervix, uterus, fallopian tubes would develop. Q5. A 16-year-old sexually active nulliparous white female complains of pelvic pain and vaginal discharge. On examination, she is found to have a temperature of 39.8 degrees Celsius, 102.0 degrees Fahrenheit, pain with movement of the cervix, and tenderness and a mass in the right adnexa. According to CDC guidelines, which one of the following treatments would be appropriate? Options: A. Outpatient treatment with penicillin G procaine, Wicillin, intramuscularly, probenecid, Benamide, orally, plus doxycycline, Vibramycin, orally for 14 days and re-examination in 3 days. B. Outpatient treatment with ceftriaxone, Rocephin, intramuscularly, probenecid orally, plus doxycycline twice a day for 14 days and re-examination in 1 week. C. Outpatient treatment with cefoxitin, Mefoxin, intramuscularly, plus doxycycline twice a day for 14 days and re-examination in 10 days. D. Hospitalization for treatment with cefoxitin intravenously and doxycycline orally twice a day to complete 14 days of treatment. Answer is D. Hospitalization for treatment with cefoxitin intravenously and doxycycline orally twice a day to complete 14 days of treatment. Explanation: patients with PID and tubo-ovarian abscess and high fever should be hospitalized and treated for at least 24 hours with intravenous antibiotics. Amoxicillin and penicillin G-procaine are no longer recommended because of the increasing prevalence of penicillinase producing and chromosomally mediated resistant Neisseria gonorrhoeae. If cefoxitin is used intramuscularly for outpatient treatment, it should be combined with probenecid. If ceftriaxone is used for outpatient treatment, probenecid is not required. Re-examination should be done within 3 days of initiation of therapy. Q6. A 16-year-old female presents with a complaint of pelvic cramps with her menses over the past 2 years. She describes her periods as heavy and says they occur once a month and last for 7 days, with no spotting in between. She has never been sexually active and does not expect this to change in the foreseeable future. An abdominal examination is normal. Which one of the following would be the most appropriate next step? Options: A. A pelvic examination. B. Ultrasonography. C. A TSH level. D. Naproxen prior to and during menses. Answer is D. Naproxen prior to and during menses. Explanation: this patient is experiencing primary dysmenorrhea, a common finding in adolescents, with estimates of prevalence ranging from 20% to 90%. Because symptoms started at a rather young age and she has pain only during menses. Endometriosis or other significant pelvic pathology is unlikely. An infection is doubtful, considering that she is not sexually active and that symptoms have been present for 2 years. In the absence of red flags, a pelvic examination, laboratory evaluation, and pelvic ultrasonography are not necessary at this time. However, they can be ordered if she does not respond to simple treatment. NSAIDs such as naproxen have a slight effect on platelet function, but because they inhibit prostaglandin synthesis, they actually decrease the volume of menstrual flow and lessen the discomfort of pelvic cramping. Acetaminophen would have no effect on prostaglandins. Q7. A 16-year-old girl present to your office for gynecologic evaluation. She has never had any vaginal bleeding. She does not recall ever having started her breast development, nor has she had any growth of axillary or pubic hair. Her height is 59 inches. On routine physical examination, you see cubitus valgus of the elbows, excess skin of the neck, and a shield-shaped chest with wide-spaced nipples. What is the most appropriate next step in her evaluation? Options: A. Hormone replacement therapy. B. Growth hormone therapy. C. Estradiol serum level. D. Pelvic ultrasonography. E. Gonadotropin levels. Answer is E. Gonadotropin levels. Explanation: this picture is a classic example of a phenotypic Turner syndrome female. 99% of all monosomy X fetuses will spontaneously abort. Congenital lymphatemia in utero leads to the development of a cystic hygroma along with many of the other visible external manifestations. About 60% of Turner patients have total loss of one X chromosome. The remainder have either a structural abnormality in one of the X chromosomes or mosaicism with an abnormal X. Other phenotypic findings include a high-arched palate, renal abnormalities, horseshoe kidney, partial or complete duplication, etc., and a low posterior hairline. 1/3 of these women will have cardiovascular abnormalities, coarctation of the aorta, bicuspid aortic valve, etc. Autoimmune disorders such as Hashimoto's thyroiditis and Addison's disease are common. The general recommendations are that gonadotropin levels are the first test indicated when the clinical picture of a classic Turner syndrome patient presents. A karyotype will confirm the diagnosis and help determine further recommendations should any Y chromosomal elements exist. A. This patient will require hormone replacement therapy as she has no ovaries. It is not, however, the next step in the evaluation. B. Growth hormone therapy in childhood has been suggested to allow these patients to approach near normal height in adulthood. It is controversial at present. C. As no secondary sexual characteristics due to estrogen have appeared, an estradiol level will not be required. D. Pelvic ultrasound may demonstrate tissue in the region of the adnexa. The streak gonads measure about 0.5 by 2.0 centimeters. Q8. A 16-year-old woman presents to the emergency department complaining of severe left-sided pelvic pain and vaginal spotting. Her last menstrual period was 6 weeks ago. A quantitative beta-HCG is 9.000 μ per milliliter. An endovaginal ultrasound notes a complex left adnexal mass, moderate free fluid, and no evidence of an intrauterine sac. The most likely site of this pregnancy is options: A. Cervix, B. Uterine cornua, C. Isthmus of the fallopian tube, D. Ampulla of the fallopian tube, E. Fimbria of the fallopian tube. Answer is D. Ampulla of the fallopian tube. Explanation: the most likely site of an ectopic pregnancy is the ampulla. Cervical, ovarian, and abdominal ectopics are very rare. Connual ectopics often present later, and the rupture can be much more catastrophic due to the vascularity of this portion of the uterus. A. Cervical pregnancies can lead to massive bleeding. The cervix will often feel very large and can be tender. Methotrexate therapy may decrease the need for hysterectomy. B. Corneal pregnancies often present later in gestation. When these rupture, due to their size and location near branches of the uterine arteries, the blood loss can be acute and massive. C. Less common than ampullar ectopics. E. See answer to C. Q9. A 17-year-old girl complains of severe bleeding during her menstrual cycle. She uses 20 tampons per cycle, and it lasts for 7 days and comes every 2 months. What is the most appropriate management? Options: A. NSAIDs, B. Iron, C. Use more tampons, pads, D. OCP. Answer is D. OCP. Explanation: menorrhagia is a term used to define menstrual periods lasting longer than 7 days. Drug therapy for menorrhagia may include iron supplements. If the condition is accompanied by anemia, your doctor may recommend that you take iron supplements regularly. If your iron levels are low but you're not yet anemic, you may be started on iron supplements rather than waiting until you become anemic. Nonsteroidal anti-inflammatory drugs, NSAIDs. NSAIDs such as ibuprofen, Advil, Motrin, others, help reduce menstrual blood loss. NSAIDs have the added benefit of relieving painful menstrual cramps. Dysmenorrhea, oral contraceptives, OCPs. Aside from providing effective birth control, oral contraceptives can help regulate ovulation and reduce episodes of excessive or prolonged menstrual bleeding. Q10. A 17-year-old girl consults in the outpatient clinic because of painful menstrual periods. She missed 3 days of school per month. Pelvic exam is normal. Which one of the following measures is most appropriate in the initial management of this patient? Options: A. Diagnostic laparoscopy, B. Danazol, C. Oral prostaglandin inhibitor, D. Codeine and acetaminophen combination, E. Reassurance. Answer is C. Oral prostaglandin inhibitor. Explanation: dysmenorrhea is pelvic pain with menses. Primary dysmenorrhea begins during adolescence and cannot be explained by structural gynecologic disorders. Usually, secondary dysmenorrhea begins during adulthood and is due to underlying pelvic abnormalities. Diagnosis is clinical and by exclusion of structural disorders with pelvic ultrasonography and tests directed at any other clinically suspected causes. Underlying disorders are treated. Pain is treated with NSAIDs and sometimes with low-dose estrogen-progestin contraceptives. Nonsteroidal anti-inflammatory drugs, NSAIDs, block the COX enzymes and reduce prostaglandins throughout the body. As a consequence, ongoing inflammation, pain, and fever are reduced. Q11. A 17-year-old high school student presents to the office for emergency contraception. Last night, she had unprotected sex with her boyfriend and does not want to risk unwanted pregnancy. Her last menstrual period was 17 days ago. Physical exam is unremarkable. What is the most appropriate next step of management of this patient? Options. A. Emergency contraception would be too late at this point. B. Reassure and send her home, since the risk of pregnancy is too low. C. Prescribe ethinyl estradiol and levonorgestrel to be taken now and after 12 hours. D. Prescribe esterone-only pills. E. Prescribe single IM injection of medroxyprogesterone. Answer is C. Prescribe ethinyl estradiol and levonorgestrel to be taken now and after 12 hours. Explanation. Emergency or postcoital contraception has become necessary since around 50% of the pregnancies in Canada are unplanned. It is highly effective with a success rate of 99%. A combination of estrogen, ethinyl estradiol, and progesterone, levonorgestrel, is usually prescribed. 2 tablets should be taken as soon as possible, within 72 hours of the intercourse, and 2 others 12 hours later. Plan B. Levonorgestrel is also used, has great efficacy and less side effects. It is not too late because emergency contraception is effective if given within 72 hours. 3 days of the sexual intercourse. Period between 10 and 18 days of the cycle is an unsafe period. The risk of pregnancy in this patient is significant and a postcoital contraception should be administered. Q12. A 17-year-old white female has had no menstrual period for the last 6 months. She has no significant previous medical history, but admits to a history of irregular periods since menarche at age 14. A urine pregnancy test is negative and a physical examination is unremarkable. The most appropriate initial workup of this patient would include which one of the following? Options. A. Reassurance and reevaluation in 1 month. B. Measurement of serum TSH and prolactin. C. Administration of conjugated estrogens. D. Abdominal ultrasound. E. A CT scan of the brain. Answer is B. Measurement of serum TSH and prolactin. Explanation. Menses are often irregular in young adolescents. However, menstrual cycles usually become regular within 2 years after menarche. Secondary amenorrhea is present when a female who has been menstruating has not had a period for more than 3 cycle intervals, or 6 months. Once pregnancy has been ruled out, a disturbance in the hypothalamic pituitary ovarian axis should be investigated. Q13. A 17-year-old white female visits you for a physical examination prior to entering college. During the review of systems, her only complaint is cyclic lower abdominal cramps around the onset of menstruation. She reports that pain has been present to some degree with most of her periods since about 6 months. After menarche, the pain is often severe enough for her to miss school. Each episode lasts 24 to 48 hours and is somewhat relieved by rest and acetaminophen. Her menstrual history is otherwise normal. She denies ever being sexually active and tells you that she has received little empathy from her mother, who has similar symptoms as an adolescent that improved after her first pregnancy. Pelvic and rectal examinations are within normal limits. Which one of the following management choices would be appropriate at this time? Options. A. Referral for hysterosalpingography. B. Referral for psychological counseling. C. Danazol, Danacrin. D. Acetaminophen, hydrocodone, Vicodin HP. E. Naproxen sodium, Anaprox. Quote. Answer is E. Naproxen sodium, Anaprox. Explanation. The patient's history is typical of primary dysmenorrhea, defined as severe cramping pain in the lower abdomen that occurs during menses. It may also occur prior to the onset of menses in the absence of associated pelvic pathology. Although many women complain of pain beginning with the first cycle, symptoms usually begin at the onset of ovulation around 6 to 12 months after menarche. Symptoms typically last 48 hours or less, but sometimes may last up to 72 hours. It is common to find daughters with dysmenorrhea whose mothers had the same symptoms. In this patient, who has no history suggesting an emotional disorder, there is no need for psychological counseling at this time. Further evaluation could include ultrasonography to rule out causes of dysmenorrhea such as uterine leiomyomata, adnexal masses, and endometrial polyps. However, a trial of symptomatic therapy is most reasonable before other invasive studies, such as a laparoscopic examination or a hysterosalpingogram, are ordered. It is not reasonable to begin danazol without a diagnosis of endometriosis, which is by definition secondary dysmenorrheal, since neither inhibits prostaglandin synthetase. Acetaminophen, which she had already tried without complete relief, combined with a narcotic is not an appropriate management strategy. Multiple placebo-controlled studies have shown that NSAIDs such as naproxen, at the onset of symptoms, provide significant relief of primary dysmenorrhea compared to placebo. Q14. A 19-year-old patient presents with acne on her face and increased hair growth on her body. During physical exam you palpate an adnexal mass. What is the most likely diagnosis? Options. A. Ovarian tumor. B. Dermoid cyst. C. Idiopathic androgen secretion. D. PCOS. Answer is D. PCOS. Explanation. Polycystic ovary syndrome, PCOS, is characterized by mild obesity, irregular menses or amenorrhea, and signs of androgen excess. Hirsutism. Acne. Typically, the ovaries contain multiple cysts. Typically, ovaries contain many 2 to 6 mm follicular cysts and sometimes larger. Testing includes pregnancy testing and measurement of serum estradiol, follicle-stimulating hormone, prolactin, and thyroid-stimulating hormone. Diagnosis is confirmed by ultrasonography showing greater than 10 follicles per ovary. Q15. A 19-year-old college freshman consults you at the request of her cross-country coach because she has not had a period in 2 of the last 3 months. She notes that her current training regimen is much more intense than in high school last year. She has an appropriate body image and denies caloric restriction. A pregnancy test at the Student Health Center was negative. On examination, she is lean and highly trained. Her examination is otherwise normal. Which one of the following would be the most appropriate recommendation for this patient? Options. A. Estrogen supplementation. B. Cyclic oral contraceptive pills. C. Increased caloric intake, D. Bisphosphonate therapy, E. Discontinuation of elite-level athletics. Answer is C. Increased caloric intake. Explanation. This patient has exercise-related oligomenorrhea, but does not have the eating disorder that characterizes the female athlete triad. Menstrual problems in athletes do correlate with bone density loss and impaired recovery from exercise. Additionally, menstrual irregularity of varying severity is extremely common in female distance runners, perhaps affecting as many as 60%. Hormonal manipulation has not been shown to affect bone density, though it may produce withdrawal bleeding. Bisphosphonate therapy has been shown to be ineffective and is not recommended in women of childbearing age. The main issue in well-nourished female athletes seems to be that energy intake is not increased to match energy expenditures at high levels of training. Unlike those with the female athlete triad, there is little evidence that athletes without eating disorders suffer substantial harm from exercise-induced menstrual problems. Ending an athletic career for this reason alone is not justified. Q16. A 19-year-old nulligravid healthy woman comes to see you for her annual pap smear and routine healthcare maintenance. During your routine pelvic exam, you note that she has a 5 cm cystic, non-tender, mobile mass in her left adnexa. Rectovaginal exam confirms this and does not note any abnormalities in the cul-de-sac. Transvaginal ultrasonography results are consistent with pelvic exam findings. Which of the following is the most appropriate next step? Options: A. Laparotomy with ovarian cystectomy, B. Repeat ultrasound in 2 months, C. MRI scan of the pelvis, D. Serum Ca-125, E. Laparoscopy with ovarian cystectomy. Answer is B. Repeat ultrasound in 2 months. Explanation. The most common cause for a cystic enlargement of the ovary in a reproductive age woman is a functional cyst, follicular or corpus luteum. These are thin-walled and usually resolve or rupture spontaneously. Any cystic mass 6 cm or less can be followed for 2 cycles. Some texts recommend using oral contraceptive pills to decrease the gonadotropin stimulation of the ovary during this time, but there is no literature that shows any improvement over simple observation. If the mass persists, further evaluation and possible surgical intervention is indicated. Laparoscopic surgery is less invasive and just as successful as laparotomy, as most cystic masses in the adnexa are functional cysts that resolve spontaneously. No other workup is indicated at this time. Q17. A 19-year-old premagravid at 40 weeks gestation has been in labor for the last 8 hours. Fetal heart tones have a baseline for 135 per minute with normal variability, multiple accelerations and no decelerations. She has been completely dilated for the last hour, and with pushing, has descended from a +1 station to a +3 station at present. The vertex is direct occiput anterior. Your next course of action is to recommend options: A. Forceps-assisted vaginal delivery, B. Vacuum-assisted vaginal delivery, C. Continue to push, D. Pitocin augmentation, E. Cesarean section. Answer is C. Continue to push. Explanation. This patient is progressing in normal fashion. She is allowed up to 2 hours in the second stage and even longer if the heart tones are reassuring. There is no need to intervene, and one would anticipate that the patient will be having a normal spontaneous vaginal delivery within the next hour. A. The patient has made adequate descent in the last hour. She can push for at least another hour and maybe more if the fetal condition remains reassuring. No indication for instrumental vaginal delivery is present. B. The patient has made adequate descent in the last hour. She can push for at least another hour and maybe more if the fetal condition remains reassuring. No indication for instrumental vaginal delivery is present. D. The patient has made adequate descent in the last hour. She can push for at least another hour and maybe more if the fetal condition remains reassuring. Since progress has been made, there is no need to augment the labor with Pitocin. E. The patient has made adequate descent in the last hour. She can push for at least another hour and maybe more if the fetal condition remains reassuring. No indication for cesarean delivery is present. Q18. A 19-year-old white female presents for an initial family planning evaluation. Specifically, she is interested in oral contraception. She is not presently sexually active, but has a steady boyfriend. She has no contraindications to oral contraceptive use. She has mild acne vulgaris. You discuss possible side effects and benefits of combined oral contraceptives, including improvement of her acne. Which one of the following is also associated with oral contraceptive use? Options. A. Increased risk of ovarian cancer. B. Decreased risk of ovarian cysts. C. Increased risk for ectopic pregnancy. D. Increased incidence of dysmenorrhea. Answer is B. Decreased risk of ovarian cysts. Explanation. Women who take combination oral contraceptives have a reduced risk of both ovarian and endometrial cancer. This benefit is detectable within a year of use and appears to be persistent for years after discontinuation. Other benefits include a reduction in dysfunctional uterine bleeding and dysmenorrhea, a lower incidence of ovarian cysts, ectopic pregnancy and benign breast disease, and an increase in hemoglobin concentration. Many women also benefit from the convenience of menstrual regularity. All combination oral contraceptives raise sex hormone-binding globulin and decrease free testosterone concentrations, which can lead to improvement in acne. Q19. A 19-year-old woman with regular menses and a 28-day cycle now presents with 8 weeks of amenorrhea. If her last menstrual period was April 17, using Nagel's rule, you would anticipate that her estimated date of confinement, EDC, is options. A. January 17, B. January 24, C. July 24, D. February 17, E. January 10. Answer is B. January 24. Explanation. Nagel's rule is used to estimate when 40 completed weeks of pregnancy have occurred. Add 7 days and subtract 3 months from the LMP will result in the EDC. This rule requires the woman to have regular cycles of normal length. A. For this date to be her EDC, her LMP would have been April 10. C. For this date to be her EDC, her LMP would have been October 17. D. For this date to be her EDC, her LMP would have been May 10. E. For this date to be her EDC, her LMP would have been April 3. Q20. A 20-year-old college student presents with lower abdominal pain and fever. Physical exam shows bilateral lower abdominal tenderness. Her vaginal exam shows tenderness with cervical mobilization. Her pregnant test is negative. What is the most likely diagnosis? Options. A. Acute salpingitis. B. Ectopic pregnancy. C. UTI. D. Trichomonas. Answer is A. Acute salpingitis. Explanation. Pelvic inflammatory disease is infection of the upper female genital tract, the cervix, uterus, fallopian tubes, and ovaries. Abscesses may occur. Common symptoms and signs include lower abdominal pain, cervical discharge, and irregular vaginal bleeding. Long-term complications include infertility, chronic pelvic pain, and ectopic pregnancy. Pelvic inflammatory disease, PID, results from microorganisms ascending from the vagina and cervix into the endometrium and fallopian tubes. Infection of the cervix, cervicitis, causes mucopurulent discharge. Infection of the fallopian tubes, salpingitis, and uterus, endometritis, tend to occur together. If severe, infection can spread to the ovaries, oophorytis, and then the peritoneum, peritonitis. These infections are called salpingitis even though they involve other structures. Diagnosis includes PCR of cervical specimens for Neisseria gonorrhoeae and chlamydia. Microscopic examination of cervical discharge, usually, and ultrasonography or laparoscopy, occasionally. Treatment is with antibiotics. Q21. A 20-year-old patient has urinary frequency and dysuria. Pelvic examination reveals a yellow discharge at the cervix and mild adnexal tenderness. The best immediate test to aid your diagnosis is: options. A. Gram stain of a cervical smear. B. Peripheral leukocyte count. C. Cervical smear for chlamydia trachomatis. D. Cervical culture on Thayer-Martin medium. E. Dipstick urinalysis of specimen obtained by bladder catheterization. Answer is a gram stain of a cervical smear. Explanation: a mucopurulent cervicitis, along with urinary symptoms, makes one highly suspicious for Neisseria gonorrhoeae, although all of the above tests would be helpful in determining the diagnosis. The only test that can aid you immediately is a gram stain. The gram stain has a sensitivity of only 60%, but a specificity of 95%. The key finding is a gram-negative intracellular Diplococcus B, often with a gonococcal cervicitis. The peripheral white blood cell count is normal. C. Chlamydial testing of the cervical smear is not an immediate test. D. Cervical culture on Thayer-Martin medium is confirmatory, but is not an immediate test. E. The urinary symptoms most likely are due to gonococcal urethritis as well as a cervicitis. Routine dipstick urinalysis will not identify the pathogen involved. Q22. A 20-year-old primogravid comes to you for her first prenatal visit at 12 weeks. She works in a daycare facility and developed a maculopapular rash at 11 weeks gestation. It disappears after 3 days and she feels fine. Options. A. You should reassure her since the symptoms were mild. B. Offer termination of the pregnancy. C. Obtain her rubella IgG titer. D. Obtain a throat culture and treat with penicillin for 10 days. E. Obtain a toxoplasmosis IgG titer. Answer is C. Obtain her rubella IgG titer. Explanation: if a woman is non-immune to rubella, then the risk of congenital rubella syndrome is 20% for a primary infection in the first trimester. Cataracts, patent Ducut's arteriosus, and deafness are the most common findings. In this case, she is coming to you within a few days of having an exanthem. If the patient's rubella IgG shows immunity, then the rash was not due to rubella. If she is rubella IgG negative, then obtain an IgM titer. A. Rubella infection in an adult can be a mild viral exanthem. This finding should never be ignored in a pregnant female. B. No diagnosis of the condition has been made at this time. D. Streptococcal pharyngitis is usually associated with a fever, lymphadenopathy, and pharyngeal symptoms. E. Toxoplasmosis is not associated with a maculopapular rash. Q23. A 20-year-old single white female who is a patient of yours was raped in her apartment at 7 o'clock a.m. today. She is brought to your office at 9 a.m. for assessment and treatment. Despite having occasional intercourse with her boyfriend, she has never used any type of contraceptive. Their last intercourse was approximately 1 week ago, and the boyfriend has been out of town on business since then. The patient has a history of irregular periods, and her last normal period was approximately 2 weeks ago. You note live sperm on a wet mount, in addition to many other issues that must be addressed at this visit. The patient asks about emergency contraception. Which one of the following would be accurate advice to the patient regarding this topic? Options. A. Emergency contraception does not interfere with an established post-implantation pregnancy. B. The estrogen-progestin combination regimen appears to be more effective than the levonorgestrel-only regimen. C. To be most effective, each dose of the two-dose regimen should be administered at least 72 hours apart. D. Fetal malformations have been reported as a result of the unsuccessful use of the high-dose emergency contraceptive regimen. Answer is A. Emergency contraception does not interfere with an established post-implantation pregnancy. Explanation. An FDA advisory committee has recommended over-the-counter marketing of Plan B, an emergency contraceptive package that contains two 0.75 mg tablets of levonorgestrel to be taken 12 hours apart. Plan B is one of the 2 FDA-approved products for this indication. The Previn Emergency Contraceptive Kit includes 4 tablets, each containing 0.25 mg of levonorgestrel and 50 g of ethinyl estradiol. These are taken 2 at a time 12 hours apart, in a randomized, controlled trial comparing the single versus combined estrogen-progestin. The single drug regimen was shown to be more effective. Pregnancy occurred in 11 of 976 women, 1.1%, given levonorgestrel alone, and in 31 of 979, 3.2%, given ethinyl estradiol plus levonorgestrel. The proportion of pregnancies prevented, compared to the expected number without treatment, was 85% with levonorgestrel and 57% with the combination. In both regimens, the interval between individual doses is 12 hours. In this case, emergency contraception may be appropriate in the face of a possible pregnancy from previous consensual intercourse. Emergency contraception has not been found to interfere with an established post-implantation pregnancy. Furthermore, no fetal malformations have been reported as a result of the unsuccessful use of high-dose oral contraceptives for emergency contraception. Q24. A 20-year-old woman at 8 weeks gestation, G1P0, would like to be screened as soon as possible to determine whether her fetus is a carrier of a familial genetic disorder. Your best next step is to Options. A. Perform an amniocentesis immediately. B. Arrange for an amniocentesis in 2 weeks. C. Perform chorionic villus sampling, CVS, immediately. D. Arrange for chorionic villus sampling, CVS, in 2 weeks. E. Perform a maternal serum, triple, screen immediately. Answer is D. Arrange for chorionic villus sampling, CVS, in 2 weeks. Explanation. Gestation-dependent screening investigations, in order to maintain pregnancy loss rates, due to procedure, of less than 1%, the earliest that a chromosomal investigation can be performed is at 10 weeks. Generally in the way of CVS. Thus, an appointment for CVS should be arranged for the patient in 2 weeks. At 10 weeks gestation, See below for general screening guidelines. Pearl. Chorionic villus sampling is performed between 10 and 12 weeks gestation. Q25. A 20-year-old woman who is 35 weeks pregnant with her first child is admitted to the hospital. Because of persistent hypertension and 1+ protein on urinalysis obtained 36 hours ago, she is confined to bed awaiting further diagnostic studies for preeclampsia. Her blood pressure is now 160/100 mm Hg. She is complaining of headaches, blurred vision and epigastric pain. At this time it is most appropriate to conclude that this patient has which of the following? Options. A. Chronic hypertension and requires antihypertensive therapy. B. Chronic hypertension, but no antihypertensive therapy is necessary. C. Mild preeclampsia and should continue bed rest pending further diagnostic studies. D. Severe preeclampsia and requires immediate medical management and delivery. E. Severe preeclampsia and should continue bed rest pending further diagnostic studies. Answer is D. Severe preeclampsia and requires immediate medical management and delivery. Explanation. This patient has severe preeclampsia. Preeclampsia is diagnosed on the basis of her elevated blood pressure and proteinuria occurring after 20 weeks gestation. She has severe preeclampsia on the basis of her headaches, blurred vision, and epigastric pain. This patient requires magnesium sulfate to prevent eclampsia. Seizures occurring in the setting of preeclampsia. Magnesium sulfate has been shown to be the most effective agent to use for the prevention of seizures in women with preeclampsia. She also requires delivery to arrest the disease process. Delivery is the only cure for preeclampsia. Bed rest pending further diagnostic studies is inappropriate because delivery is necessary to prevent a worsening of the disease process that can be fatal for mother and fetus. Q26. A 20-year-old female college tennis player presents with painful anterior lower leg lesions. You note several 2 to 3 cm wide, tender, warm lesions over both shins. The patient denies specific trauma or increased exercise. The most significant etiology to be considered in this case is options. A. Papular urticaria. B. Early rheumatoid arthritis. C. Shin splints. D. Superficial thrombophlebitis. E. Oral contraceptive use. Answer is E. Oral contraceptive use. Explanation. This patient has typical erythema nodosum, likely related to oral contraceptive use. Careful evaluation of the skin lesions would exclude early rheumatoid arthritis, shin splints, and superficial thrombophlebitis. Papular urticaria, a hypersensitivity reaction to common insect bites such as fleas, mosquitoes, bedbugs and other insects, is another possibility to consider, although these lesions are generally smaller and papular or papulovesicular in appearance. Q27. A 20-year-old female is seen for follow-up 6 weeks after delivery. Her pregnancy was complicated by preeclampsia. Her examination is unremarkable. This patient will be at increased risk for which one of the following in midlife? Options. A. Breast cancer. B. Diabetes mellitus. C. Hypothyroidism. D. Kidney disease. E. Hypertension. Answer is E. Hypertension. Explanation. Preeclampsia affects as many as 5% of first pregnancies and is manifested as hypertension, proteinuria, edema, and rapid weight gain after 20 weeks gestation. Very young mothers and those over age 35 have a higher risk. Patients who have had preeclampsia have a 4-fold increased risk of hypertension and a 2-fold increased risk of ischemic heart disease, stroke, and venous thromboembolism. There does not appear to be an association between preeclampsia and cancer. Breast cancer in particular. Q28. A 20-year-old female long-distance runner presents with a 3-month history of amenorrhea. A pregnancy test is negative, and other blood work is normal. She has no other medical problems and takes no medications. With respect to her amenorrhea, you advise her. Options. A. To increase her caloric intake. B. That this is a normal response to training. C. To begin an estrogen-containing oral contraceptive. D. To stop running. Answer is A. To increase her caloric intake. Explanation. Amenorrhea is an indicator of inadequate calorie intake, which may be related to either reduced food consumption or increased energy use. This is not a normal response to training, and may be the first indication of a potential developing problem. Young athletes may develop a combination of conditions, including eating disorders, amenorrhea, and osteoporosis. The female athlete triad. Amenorrhea usually responds to increased calorie intake or a decrease in exercise intensity. It is not necessary for patients such as this one to stop running entirely. However, Q29. A 20-year-old multiparous woman underwent AFP testing at 16 weeks gestation. The initial result was 0.3 multiple of the median. Mom. Normal 0.5 to 2.0 mom. The result of a repeat test performed 5 days later was 0.2 multiple of the median. The abnormality most likely to be associated with these results is options. A. Trisomy 21. B. Triploidy. C. Twin pregnancy. D. Meningomyelocele. E. Trisomy 13 inches. Answer is A. Trisomy 21. Explanation. Due to the large overlap between a normal fetus and a fetus with trisomy 21 or 18, low alpha fetoprotein values should not be repeated, as the second value is more likely to be reported as normal. Regression to the mean. Most patients now receive a triple screen, which includes AFP, HCG, and UE3. This triple screen test looks at the age-related risk for aneuploidy for each of the markers and then predicts a composite risk for both trisomy 21 and trisomy 18. With the triple screen, about 60 to 70% of all trisomy 21 pregnancies can be detected prenatally. In trisomy 18, all three values are low. Trisomy 13 cannot be screened by a low MSAFP. B. Triploidy is not associated with a low MSAFP. C. Twin pregnancy is often associated with an elevated MSAFP when compared to a singleton pregnancy. D. Open neural tube defects are associated with an elevated MSAFP. E. Trisomy 13 cannot be routinely detected by the MSAFP value. Unlike trisomies 18 and 21. Q30. A 21-year-old female is currently being treated for chlamydial cervicitis with azithromycin. Zithromax. 1 gram in a single dose. She had a pelvic examination and a normal Papa-Nicolau (PAP) test 3 months ago. When should she next have a test for chlamydia? Options. A. 3 to 4 weeks. B. 1 to 2 weeks. C. 9 months. At her next routine pelvic examination. D. Never. Unless she is symptomatic or has a suspected exposure to chlamydia at some point in the future. E. In 12 months. Answer is E. In 12 months. Explanation. A test for cure for chlamydia is no longer recommended because of the efficacy of treatment and the persistence of a false positive polymerase chain reaction, PCR. Test for chlamydia in the cervix for as long as 3 to 4 weeks despite treatment. Test of cure is required in pregnancy. Cure rates lower in pregnant patients. Therefore, pregnant women should be retested 3 to 4 weeks post-initiation of therapy. CDC recommends yearly chlamydia testing of all sexually active women aged 25 or younger. Older women with risk factors for chlamydial infections. Those who have a new sex partner or multiple sex partners. And all pregnant women.